So when I have a patient with Richter's transformation, they are typically a patient who's never received treatment, or they are a patient who's received treatment and then developed Richter's transformation. Based on our data that we're presenting here at ASH 2023, patients who've received treatment with small molecule inhibitors do far worse than those patients who've never received treatment. And the question is why? I think there are multiple reasons for this. I think that never receiving treatment is likely a surrogate for aggressive disease, specifically clonality. And so when I say clonality, what I mean is the CLL clonally related to the Richters? Did it literally transform into an aggressive lymphoma? And as we all know, when cancers literally transform into something, it's never good. It's because they usually have higher mutational burden, they act worse, they have more aggressive disease, as opposed to somebody with CLL who just so happens to get diffuse large B-cell lymphoma on top of their CLL. And so I think that most likely it's a surrogate for clonality, it's a surrogate for more aggressive disease. So that's one reason why these patients who receive therapy do so much worse. And so therefore, should this change our management? Should this change the way that we treat patients? So I think that I'm more likely to give somebody standard chemoimmunotherapy who's never received treatment. Our data shows that if you've never received treatment and you get chemoimmunotherapy, it might be a little bit better than some of the new things that we have, because those patients probably are more likely to have just regular old diffuse large B-cell lymphoma in the setting of CLL. Whereas those patients who develop Richters after getting a small molecule inhibitor, our data shows that really no treatment works very well. And so for those patients, I would really try to put that patient on a clinical trial. That would be the number one thing. And even patients who develop concurrent Richters without receiving treatment, I would try to get into a clinical trial too, to be honest. But I would really try to get those patients onto clinical trials. So a couple of clinical trials that we have available at The Ohio State University, which I'm excited about, are the venetoclax plus R-CHOP trial. I've had some really good responses on that trial, even for patients who've received prior small molecule inhibitors. And hopefully we'll get an update on that data sometime in the next year. We also have a new investigator-initiated trial, which is zanubrutinib, the BTK inhibitor, plus CAR T-cell therapy that we're excited to see. And that trial allows for patients to go on study if they've developed the Richters on their last CLL therapy, so they don't necessarily need to fail one prior line of therapy before going on study. And then we have another investigator-initiated trial out of Cornell that we're helping with too, that combines polatuzumab with R-EPOCH. So I think we have a lot of trials that are available for our patients with Richter's transformation, and for someone who's received prior treatment, I would go directly to a trial because we know that what we're currently doing doesn't work, so we have to try something new.